Okay, so we're going to talk about chapter 15, which includes the blood vessels and capillary exchange. So we're going to get into some kind of capillary exchange because that's where gas and nutrients are actually exchanged. So that's kind of an important area. And then we'll talk about blood flow and blood pressure and a little bit about control. So we're going to learn exactly what we're doing when we're taking blood pressure. Okay, so first of all, remember that when we talk about flow of blood through the body. If we look at systemic circulation, so systemic circulation means it comes from the left ventricle, remember, oxygenated blood, and then it will break into, so first of all, enters the aorta, and then it will enter into arteries. Okay, so technically the aorta is considered an artery because it's leaving the heart, but it will divide into like the brachial artery, and we mentioned some of those things in previous sections. And then it divides into arterioles. Now, arterioles shows these little clamps here because that's where a lot of vasodilation and vasoconstriction takes place. Vasodilation is when the blood vessel goes from being relatively small to larger in diameter. Okay, so that's dilated. And then vasoconstriction is the opposite, where it might be small or it may be large, and then it goes to a smaller diameter. So that's constriction. Okay, and so this is trying to show that this is where the control takes place. It takes place in the arterioles. So they have smooth muscle around them, which we'll see a picture of in the next slide. And so you can control how much blood flows into the capillaries. And then in the capillaries, you have this exchange. So oxygen is moving to the capillaries and carbon dioxide is moving out. Now, carbon dioxide also causes a pH change, so the pH drops where there's a lot of carbon dioxide. We'll discuss that even more when we talk about respiration, because that's one of the ways that blood pH is controlled. But around the cells, the pH tends to be very low, which means it has a high hydrogen concentration around the cells. So it's a metabolically active cells are kind of a messy place, and so we're trying to get rid of all that. And trying to kind of clean that up and then provide it with more nutrients, things like also like glucose. So all of that stuff takes place through the capillaries. So that's why the color change happens here, because you go from oxygenated blood and then it gives up that oxygen, and then it's deoxygenated blood, and of course that's rich, if you want to call it that, being a waste product, but it has a lot of carbon dioxide in it. And then it goes over here through the venules, which are small veins. That's what that is. And then it moves through the veins, the larger veins, and you can see that a lot of the blood flow through the larger veins is because of these one-way valves, because the velocity is or the pressure is very, very low in these areas, so it takes, your muscles will actually squeeze it, and these one-way valves keep it moving in this direction, and it goes back to the right atrium, right ventricle, and then to the lungs where it picks up more oxygen. And it just keeps doing this all the way through the body. So you've got the systemic circulation here, and then you have this smaller pulmonary circulation here. So that's kind of your review of what's going on with a little bit of new information. Okay, so if we look at the different vessels, we have arteries, which arteries are big. They're very large. They have a lot of elastic tissue. They have a lot of smooth muscle, so they can control blood flow to major areas by either tightening or loosening up to dilate. Okay, they also have a lot of fibrous tissue, so they're strong. But then you get to arterioles, and arterioles don't have a lot of elastic tissue. They're not as elastic, and that's okay because they aren't swelling. Okay, so remember, in the aorta, when the ventricle squeezes, it's pushing a lot of blood into that artery and into the aorta, and it will swell. And we can feel that in a pulse in the rest of our arteries. We can feel a pulse. We can feel it expanding and contracting with every beat of the heart. Okay, but in the arterioles, we don't need that because there isn't as much expansion and contraction. However, there is smooth muscle. Okay, there is smooth muscle, which means that these arterioles can control blood flow, and we just saw that in the previous slide, and that's what these were trying to show, is they were trying to show that these smooth muscles can contract and they can control the blood flow through the capillary. So if you need more exchange, it might, slow it down a little bit so you have higher, or speed it up so you have more oxygen coming in, or it might slow it down if it's not a very metabolically active cell. Okay, so and then it moves to the capillaries, and when you look at the capillary, you really see nothing. The capillaries are very, very thin. They just have some endothelial tissue here, which are just regular epithelial cells. And that's it. There's no smooth muscle, there's no elastic tissue, there's no fibrous tissue. It's just a small ring, which means that they're very fragile. So, and we know this because if you get hit by something like baseball or something like that, it may not even break the skin, but it will break the capillaries underneath and you end up with bruising. Okay, so these things are very fragile, very easy to break, but that's also good because that's what allows the exchange to take place, for things to move in, things to move out. They're able to do that because there are actually holes in them that we'll see as well. They're called fenestrations. Okay, so let's just talk. Oh, well, I guess I don't want to skip the venules. The venules, there's not a lot of smooth muscle control. However, there is in the veins. There is some smooth muscle control. They can dilate or they can expand. They're also pretty elastic because that's where actually most of your blood is at any one time. Most of your blood is actually in the veins, so they actually collect a lot of blood and hold a lot of blood as it sort of lopes through the veins and then back to the heart. Okay, so let's talk about what's going on with the arterioles and with the capillaries. Okay, so you have these little things, they're called capillary beds. Um, and the blood will flow through and then it sort of branches out. And now your capillaries have a lot of what we would call cross-sectional area. There are a lot of capillaries. They're all through your body. And so blood is flowing through all these. Everywhere you have cells, which is everywhere, you have capillaries surrounding them to provide them with nutrients. Okay, so as the blood is flowing through there, sort of very, 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 very slowly, velocity is slowest in the capillaries, um, and so you can have a lot of oxygen, nutrient, water is moving back and forth in and out of these. Okay, and then it goes back to the venules, and then back to the veins, and then of course back to the heart. Okay, where it picks up more, where it's then sent to the lungs for more oxygen. So let's just look at this. Let's look at the structure of these capillaries, because the capillaries actually, I remember saying that they have pores. They're not very tightly held together. These guys aren't. These guys are made to carry blood, but they're also made to be permeable. Okay, so water can go in, water can go out, water can go in to these capillaries. Now blood cells are going to be, larger. Sometimes capillaries are so small that they're almost the width of a blood cell. So if you could sort of imagine a blood cell in here, it would almost be as large as the capillary itself because they can be so tiny. Um, and so the blood cells aren't able to move through, but yet there's plenty of movement of water, glucose, ions, and then of course oxygen, carbon dioxide will also move through. So lots of ways for things to move through. Transcytosis can bring proteins and larger molecules across, and then sometimes these little bubbles will form. These vesicles will sort of form together and create a temporary pore. So yeah, the capillaries aren't working to keep anything in or out except for these larger blood vessels, and some larger proteins aren't able to get through. Um, and some of the white blood cells don't really move through, but some do. And that's sort of their job. Okay, so what tends to happen is if you think about inflammation, so if you sprain your ankle or something like that, well then what can tend to happen is this filtration. That's what we call that when the fluid moves out of a capillary. So this is the capillary here, and you have filtration of fluid that moves out. Okay, so this fluid is constantly moving out, and then it will actually move back in. Okay, and that's called absorption. Now, when you injure yourself or you have an inflammatory type of response, what tends to happen is it makes the capillary more permeable. Okay, so fluid tends to build up out here. Okay, and so you have swelling. Okay, because more fluid is being allowed to move out. Okay, so that's what happens during edema and inflammation. Now, most of that fluid that moves out will move right back in. Okay, there's something called colloidal pressure where there are a lot of particles and blood cells in here that are sort of pulling the water back in through osmosis, but you have blood pressure that's pushing it out over here. So you've got those two things sort of working together. You got blood pressure saying, pushing behind it, which is pushing the fluid out, but then you have these particles in here. Remember osmosis? Anytime you have particles, that's going to be drawing the water in if you have more particles in there. So between colloidal pressure pulling it in and and blood pressure pushing it out, or we would call that hydrostatic pressure, but you have basically what turns into almost kind of its own little circulatory system. In a way, because fluid's moving out and then back in. And of course, that's nice because it can distribute nutrients to all of these cells around here. Now, the rest of it that isn't reabsorbed or absorbed by the capillary will actually move into the lymph system. Okay, so the lymph system doesn't have a pump like the heart does. The lymph system is just sort of a network of vessels that are pretty much scavengers. Okay, so they scavenge extracellular, I'm just going to put EC fluid. Okay, that's what lymph does. And now, if you think about what happens with lymph, we know that we have lymph nodes, and when your lymph nodes are swollen, maybe you've heard this, maybe you haven't, but when your lymph nodes are swollen, it means you have an infection. Okay, well that's kind of handy because let's say you do have some bacteria or something there. That bacteria might get swept into the lymph vessels, and then it will travel, or to the lymph vessels, and then it will travel to where there might be lymph nodes, and the lymph nodes is where white blood cells will sit. Lymphocytes, like B cells and T cells, that's what they are. So they'll sit there and they might encounter these bacteria, and then they'll launch an immune response and they'll start to divide, and that's when our lymph nodes get swollen. Okay, um, so really swelling, inflammation types of things, edema, what's happening is that you're not able to clear this fluid. Okay, remember I mentioned earlier that in the veins, they aren't in venules, but in the veins you have these one-way valves that have to open and close, and a lot of times you need to move your muscles to kind of squeeze the veins to keep this blood flowing and to cause some pressure so the blood will flow through there and then up to the heart. If you don't move around very often, then your blood doesn't clear, and it creates a lot of back pressure, and again you have a buildup of fluid, and that's why a lot of people who don't move around a lot get swollen ankles and things like that because they can't clear this fluid, and that's what edema is. Okay, all right, so let's see, let's just go read through some of these facts. Bulk flow is mass movement as a result of hydrostatic or osmotic pressure gradients. Okay, so we mentioned that the hydrostatic is pushing it out for filtration, and the colloidal or osmotic pressure gradients are pulling it back in. Okay, fluid movement into capillaries is absorption, and filtration is out of the capillaries. And the other thing is that, let's see, so we have fluid moving out on the arterial end, so I just want to point that out. I kind of indicated that. It moves out on the arterial end, and it moves back in on the venous end. Okay? Okay, so let's talk about pressure in the arteries. Okay, so remember when the ventricle contracts, okay, so we're back to the heart now. Remember when the ventricle contracts, it pushes blood into the aorta or into the arteries, okay? And that causes the arteries to expand, and we can feel this as a pulse. So a pulse is the same as when you take your pulse rate, you're also taking your heart rate, because every time this squeezes, it pushes out, and we can feel that. Okay, um, and and then because it's elastic, we just mentioned that arteries tend to have a lot of elastin, the protein that's stretchy, and that means it's going to try to return to its original shape. Okay, so its original size. That's what elastic means, that it returns to its original form. And so as it tries to squeeze back, the valve closes. Remember the aortic semilunar valve? That's between the right ventricle, or the right ventricle and the aorta, the left ventricle and the aorta. Then that aortic valve will close, and it won't allow the blood to flow back into the left ventricle, and so it has no choice but to keep moving forward. Okay, so we mentioned that before. And so what we end up with is blood pressure. Okay, so we have this constant cardiac output, and we've seen this slide before. We have this constant cardiac output, this pushing out, and then the it maintains some certain level of pressure. And so we call this the average of the expansion, the maximum pressure, and the minimum pressure. We call that the mean arterial pressure. And if your blood pressure is like 120 over, 73 or something like that, then your mean arterial pressure would be kind of between those, but a little bit lower. So if you have 120 over 73 as your pressure, here's 120 and here's 73, it would probably sit right about here. Okay, a little bit lower, a little bit below half. Okay, and that's because you spend more time in diastole with your ventricle relaxed than you do with it contracting. Okay, so that's why it tends to be a little bit below the actual average between the two. So that's what mean arterial pressure is. Okay, so if we look at it throughout the duration, we can see that here in the ventricles, left ventricle, it goes all the way from almost zero up to the maximum systolic pressure, which is in this case around 120. Okay, and that's because the ventricle will empty out completely. Okay, so it empties out completely, so there's nothing left. Okay, and then it opens up and it lets it refill. So that pressure drops all the way down. It doesn't always empty out completely, but it can. And so the pressure is going to drop all the way to zero. It's letting it out, and it's actually trying to squeeze it out to get more out. Okay, that's not the case in the arteries. The arteries take in this extra blood, and then when they want to send more of it out, they want to get rid of it, they can't. Okay, it's sort of stuck in there. So they start to, if the valve would stay open so they could send it back to the ventricle, they would, but they can't. So you're sort of forcing all this blood into these arteries and arterioles and the whole vascular system, and it can only hold so much blood, so it never really drops down. And that's good, because we want to have positive blood pressure. When we cut ourselves, we want the blood to flow out. Okay, we don't want a vacuum in there where the blood where something would go, it would suck fluids in, okay, for example. Okay, so this is our systolic pressure, and this is our diastolic pressure. Okay, that's as low as the pressure that that your arteries are going to see. That's the diastolic pressure. And so we can look and we can calculate this for the entire duration as blood flows through the cardiovascular system. And you can see, so this line is mean arterial pressure, or MAP. Okay, so this is the mean arterial pressure. And so when we ignore the ups and downs and we just say, okay, it spends more time in diastole, so it's a little bit below half, this makes sense. And then we just sort of follow that. We can see, and this is kind of an important point, we can see, I'm going to change this to black so we can see it a little better. But we can see that this falls steadily all the way until it gets back to the heart. Okay, so your blood pressure, and this is an important point, so I want to pause and make sure you understand this. Your blood pressure is highest in the arteries and then it just keeps dropping. And the reason it drops is because it's banging against the walls of the vessels, and so that's absorbing some of that energy, and so it just drops, 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 drops until it gets back to the heart, and then of course when the ventricle pushes it, it starts up here again. Okay. Um, now, if you, the reason I make a big deal about this because this is pressure. Okay. So keep that straight. Remember it right now. Pressure falls from the time it leaves the heart. It just continues to fall until it gets back again to the heart. So if I were to ask you anything about where is pressure higher, is it higher in capillaries or is it higher in veins? You would say, well, it's higher in capillaries because it goes through capillaries first and then it continues to fall. Now, we're going to see in a couple of slides that that's not the case with volume or with velocity. Okay, so velocity doesn't do that. Okay, velocity is actually lowest in the capillaries. So keep those straight because they're different. So one of the reasons, let's see, make sure I didn't miss anything here. Pressure falls down, pressure gradient, so it does that. Falls over distance as energy is lost to friction. It's highest in the arteries, decreases continuously as it flows through, and the mean arterial pressure, of course, decreases. Pulse is strongest in the arteries. Okay, so that makes sense because you can kind of see that these differences kind of fade the further away they move. More highly branched vessels have lower blood volumes, and flow in the capillaries is lower. So this is velocity, which we're going to revisit, and flow in the aorta is up to 40 centimeters per second. Okay, that's actually quite a bit. That's like 16 inches. There's about 4 inches in a centimeter in 10 centimeters. So that's about 16 inches in 1 second that it flows. However, in the capillaries, it's loping along very, very slowly. And this is one of the reasons, because if you look at what happens in the arteries, okay, so we could say this is an artery, and we might say these are arterioles, okay, and then these might further divide into capillaries. Okay, so we might see that taking place, and these would all be capillaries going all over the place. All right. Now, the blood flow, it's a closed system. So yeah, we talked about some of the fluid that gets lost, and that's true, but overall, it's a closed system. So that means that as the heart pumps blood in, it has to that blood has to go somewhere. And so it's going to, even if it divides, the total blood that's going to come out is going to be the same, because even the lymph system will pump it back into the circulatory system. So the same volume of blood is pumping around, and yes, some of it moves out into your extracellular fluid, but it eventually moves back in. It has to. Okay, there's nowhere else really for it to go, unless you just inflate, which can only happen to a point. Okay, so total blood flow through 4 identical vessels, A through D, is equal, and it's going to total flow into the vessels equals the total flow out. So 4 liters per minute is going into the aorta, then 4 liters per minute is going to be coming back. Okay, now the thing is that we talked about how pressure simply falls as it moves through. Velocity decreases with more cross-sectional area. Okay, so the more cross-sectional area, and that's what this is. If these were capillaries, we would have many, many more of these. Okay, and so that's a lot more cross-sectional area. Okay, so that means that velocity is going to flow. It's kind of like if you take a river and you expand that river, and then you recontract that river. So that means that if it's flowing along at a certain pace here, as it gets to this larger part, it has more area, and so it's going to take much longer for it to move through. If you can sort of imagine in an inner tube or a canoe or something like that, you're going along at a pretty good pace, then it expands out, and then it just goes very, very slowly. And then as it narrows again, it speeds up a little bit. Okay, so even though the pressure is falling this whole time, and this would represent where we have capillaries, okay? And that's good because that's where exchange is taking place, nutrient exchange is taking place. So you don't want it to move fast through the capillaries, okay? And so that's what this graph is showing. It's showing that this total cross-sectional area, because we have capillaries everywhere throughout our body, everywhere we have cells, then you can see that there's a whole lot of cross-sectional area. So there's a big area and lots of little tiny vessels that are going to hold on to this. And so what happens is it's like the river that expands into a big vast, like almost like a pond, um, kind of a situation. So the blood flow starts out very, very fast in the aorta and the arteries, and then it falls as it moves through the arterioles, and then it's very, very slow velocity through here and the capillaries, and then it starts to speed up again. Now the pressure has dropped, um, so it doesn't go as fast in the veins, and when it gets back to the vena cava, it's not going as fast because the pressure has fallen continuously during that time, but it's still the veins, and when it gets back to the vena cava is still faster than it was in the capillary. So hopefully that makes sense. Okay, so just pointing this out again, I mentioned it before. Um, yes, lots of blood. Your total blood volume is actually more in the veins because they have high compliance, which means that they can absorb a lot of, or they can hold a lot of blood. Um, but the velocity we just saw is a little bit faster than it was in the capillaries. However, the pressure is very, 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 very low. So when you think about blood trying to move back up, let me switch back to black again. When you think about blood trying to move back up to get back to the heart, you don't have a lot of pressure pushing it, okay? And so here's this valve, and this is actually pretty cool. Here's this vessel, this vein, and here are these little valves in there. And these valves can open, and then and so when this soleus muscle or whatever muscle this is squeezes, it'll squeeze the blood, and the blood will have to go only one direction. It can't go back this way because there's a valve there. So as it squeezes, it continues to push the blood back towards the heart. So that's why activity is good for our blood flow. That's one of the reasons. Also makes our heart pump faster. Okay, so that's what we see here. We see this squeezing, and this valve will shoot open, and the blood will flow up. It can't go back, okay, because of these valves. Okay. Um, okay. So that's very important. So valves in the vein prevent backflow. When the skeletal muscle compress the veins, they force blood towards the heart. Now, I'll point out something else. And if you've ever heard of deep vein thrombosis, this would be considered a deep vein. You also have superficial veins that are out here, and sometimes you see things like spider veins when those get clogged up and the blood sort of collects and pools in them. You can see spider veins that develop, and that's less life-threatening. But if you're sitting on a plane for a long time, there's this little thing that blood does that's very interesting, and that's called clotting. Okay, and we know this. And so in blood pools, it tends to clot. So a lot of times when you're sitting on a plane or sitting somewhere for a long period of time, you'll start to form clots. And these clots might move somewhere, and they might cause a blockage. Okay, and if they cause a blockage, we call that a thrombosis. Okay, thrombocytes, platelets that clot are called thrombocytes. So we call that a thrombosis. And so we would name that a deep vein thrombosis, okay, or DVT. So that can happen sometimes, and we don't want that vein to go somewhere. It's in the vein, so it's not restricting oxygen from getting anywhere, but it's very, very painful. And if that clot gets thrown and does end up in an artery or something like that, it can be life-threatening. Okay, now let's talk about controlling pressure to some degree. Now, if you look down here, this says the radius, and it's an arbitrary number. The radius is 1. Okay, so 1 whatever, millimeter, 1 inch, whatever it happens to be. The radius of this one is 2. Okay, so when we try to control blood flow through our blood vessels, now I'm talking about controlling blood pressure. Okay, so we know that the heart is beating. We know that the heart is trying to push blood through. Okay, but we have some control over that. And one of the things that we can do is when we look at this, we can say that it has resistance, okay? And resistance means that if I have blood flowing through this vessel and blood flowing through, I'll just make it smaller, even though it's backwards from the way they did it over here, that means that the blood is flowing pretty easily in the middle. Now here you have some friction, okay, where it's kind of bumping up against the blood vessels. And so that's going to lower the pressure. It's going to cause resistance to take place here. But you've got a lot of fairly unrestricted blood flow through the center of this. Now, when your blood vessel decreases in size, so constricts, what you end up with is a lot more resistance, okay, compared to how much actual easy blood flow that you have moving through there. So what happens is as the radius decreases, okay, so this cross-sectional area, it's half of the cross-sectional area, but as the radius decreases, as it gets smaller, the resistance increases. So this says higher resistance. But what this graph is telling us is that it doesn't just increase by, okay, we doubled the radius or we decreased the radius. So if we increase the radius over in this example, so it started out as 1, this is where we began. It started out as 1 and then we doubled it, which means that we should be decreasing resistance, right? Because we've made it larger. And so we've doubled the size, but here's the thing. We're not just, so we double the radius, but we're not just doubling, or we're not just decreasing the resistance by half by doubling it. We're actually decreasing it by 1 to the 4th or 2 to the 4th. It's going to the 4th power. So that means that instead of just saying, oh, well, this is a radius of 1, so it has a resistance of, we'll just say 1, and so it went to 2, so it has the resistance is a half. It's not a half. It's actually 1 over 2 to the 4th, which means it's only 1/16 of that resistance. Okay. What does this mean? This means that, and this is the important thing, that changing or constricting or dilating your blood vessels by just a little bit has a major effect on blood pressure. Okay, because it changes the resistance so dramatically, not just a 1-to-1 ratio, but 1 over 2 to the 4th in this case. Okay, so it's always going to be something to the 4th. If we had made it 3 times the size, it would be 1 over 3 to the 4th, which is a very, very high number. Okay, all right. So small changes, and that's what comes down to. Small changes in this diameter or this radius cause big changes in blood pressure. Okay, and that's handy, right? Because that means that if we take drugs or something like that, or if we need to, if your body senses that a certain area isn't getting enough blood flow, all it has to do is dilate this, and you have an increase in blood flow, obviously, okay, because you've increased the diameter, but your blood pressure drops. Okay, so we could take a drug that's a vasodilator, and that would actually drop the blood pressure very, very quickly. Okay, so let's talk about blood pressure. We take the blood pressure with something called a sphygmomanometer. Okay, and that's what this is right here. This is a sphygmomanometer. And so here's the premise behind what a sphygmomanometer does. Okay, so let's sort of imagine. Here's a blood vessel. Let's say this is your brachial artery in your arm. Okay, and it has blood flowing through it. Okay, just fine. Blood's flowing through it. Ask yourself this question. Do you think you can hear this blood flow? Do you think you can hear the blood flowing through there? Probably not very well. Okay, we don't sit there and hum all the time. We have blood flowing through us all the time. We're not humming all the time. However, if we were to squeeze this Maybe just a little bit? Do you think you could hear it then? The answer is yes, because what happens is that blood has to turn a corner and then it starts to swirl and it will bang against that. Okay, so that will all of a sudden cause a vibration. Okay, so we can hear that vibration as the blood is flowing through, and we call that turbulence or turbulent flow. Okay, we call this laminar. Laminar just means layered, so we call that laminar flow. Okay, in laminar flow you don't hear it. Okay, so that's just blood flowing through without any disruption. However, turbulent flow, we can hear it. Okay, so let's think about what we do when we take blood pressure. Okay, first of all, we find the arm, and then okay, so this is the artery. Remember what's over here is the ventricle. Specifically, it's the left ventricle. Okay, so the left ventricle is over here and it's pushing blood. Okay, so there's a certain amount of force pushing this blood through here. And so what we're going to do, first of all, when we take blood pressure, is we're going to pump up the sphygmomanometer, okay, until guess what? We have matched, okay? Try to understand what that means. We are trying to figure out how much pressure is pushing in this direction, so we're going to squeeze this until we stop hearing any sounds over here, until there's nothing. Okay, there's no sound. Because we know at that exact moment where we have matched the pressure pushing through here, we know that that's as much pressure as the left ventricle can push. That's your maximum blood pressure. That's your left ventricle at systole. Okay, so that's what it is. That's systole. So at the point, that exact point, okay, so wish I could delete just a little bit of that, but I can't. So at some point, we may be almost there, but we can still hear it. Okay, so we're trying to push it until we blocked it completely. Okay, and at that exact point, let's say that's 120 millimeters of mercury. At that exact point, we say, okay, we figured out how much pressure that ventricle really has. We figured out how much it can push because we have matched it completely, and that was at 120 millimeters of mercury, and that's your diastolic pressure. Okay. All right, so let's look at then what do we do? Well, then we sort of relieve the pressure. Okay, so we blocked it and then we're letting it out, and then at some point, oh, it's escaped by. Okay, that's right where our systolic pressure is. And so we continue to let some of the pressure out, and we're listening, and of course we're hearing turbulent flow because we're still pressing on it. Okay? And so we can still hear turbulent flow. Okay? There's still noise. Okay? And so we keep going, and then at some point, we relieve a little more pressure. At some point, all the sound is gone again. Okay? So this is our stethoscope. Okay? So we're listening. And then at some point, all the sound is gone. And that's because this is the lowest pressure that your arteries will experience. Okay? That's the lowest pressure. So at that exact moment, and try to understand what that means, at that exact moment where all of a sudden this sound goes away, that's the pressure. Because of course, if you relieve it even more, you're still not going to hear any pressure. So you're trying to figure out exactly the point where you stop hearing any sound. And that's going to be your diastolic pressure. Let's say that happens at 70 millimeters of mercury. So that means that at 70 millimeters of mercury, that's your blood vessel. That's the pressure, the basic pressure that's always in your blood, okay, at the very least. And so that's going to be your diastolic. Okay. So then the blood pressure we just took, where we matched what the left ventricle could supply, that was 120. And then when it was completely just at that moment, when it was completely at rest, that was about 70. So that means our blood pressure. So that's going to be the diastolic because that's where the pressure was when the ventricle was relaxed, which is diastole. So that means our pressure is going to be 120 over 70. Okay, so that's how we're going to record that blood pressure. Okay, so so if we read this, the blood pressure, so maybe hopefully this makes sense given what we just went through. The blood pressure at which blood flow is stopped by the cuff is the pressure at systole. So that's the first thing we did, and that's when the pulse stops. Okay, so what you normally do is you pump it past that and then you start to relieve it. And so when you first start hearing the ventricle's able to push the blood through, you say, ah, okay, that's it. That's our systole. Okay, so while the cuff is still squeezing the artery, but allowing the blood flow through, we can hear this turbulent flow. Okay, so we hear that turbulent flow and we listen and we listen and we relieve a little more pressure. And then at that point where we can't hear it anymore, at this point right here, at the exact moment, that's when we know that that's as relief as little pressure as these blood vessels will have on them. Okay, and that's our diastolic. Okay, so that's the point at which the ventricle is completely relaxed. Okay, so that's the um, that's that's the pressure that the blood vessels have when the ventricle is completely relaxed. Okay, so that's it. So if we look at what all of this means, 120 over 80 is optimal. Our last patient was 120 over 70, so I guess that's okay. 130 over 85 is normal, and these numbers are changing actually. Okay, so you might want to pay attention to that. And then, 130 to 139, high normal, 140 or higher is called hypertension. And hypertension is just a word for um, blood pressure. Okay. So hypertension, when you have these blood vessels that are constantly under pressure, okay, it can cause damage to them, especially when we get into like the kidneys where there's so much blood flow through the kidneys and there's a lot of passing of fluids between these capillaries. I mean, that's a very important thing that happens in the kidneys, as we'll see. It can cause damage. Okay, it can cause damage to the heart itself because the heart has to pump so hard all the time. Um, the brain, some of the small vessels in the brain, and the eyes. There are lots of very tiny blood vessels, capillaries that can be damaged sometimes with that and with sugar, as we know. And so it accelerates atherosclerosis and coronary artery disease. So these are problems with the blood vessel. Um, Hardening of vessels, the wearing down of the vessels. Sometimes there's a buildup of LDLs, low density lipoproteins in the vessels, but that usually oftentimes comes from diet, but it can also come from hypertension because you have damage, and a lot of times it's a small area of damage that causes plaques to build up. All it takes is a little bit of damage, and then you have platelets that build up, and the LDLs will build up, and just everything kind of gets hung up on that area, and it just grows and grows and grows. So if that's on the inside of a blood vessel, that's not necessarily a good thing. Okay. All right. So this is one more picture showing what we just went through. This is showing a blood pressure of 120 over 80. So this is at this point where you can sort of imagine this is the exact point where the ventricle was contracting. Um, so that's ventricular, oops, not diastole, ventricular systole. So you've matched the blood pressure and you've said that it's 120. And then you have the turbulent flow, which you can hear. Okay. And then when that turbulent flow stops, and this is saying that it's around 80, then that's your diastole or diastolic pressure. Okay, and it's showing the same thing that I drew before. Complete blockage here, turbulent flow, so you can hear sound here, and then no sound. And that's what we call laminar flow. Okay, so you've got nice flow through here. Okay, All right, so we were talking about blood pressure, and the risk of developing cardiovascular disease doubles with each 20 over 10 millimeters of mercury increase in blood pressure. So this is 115 over 75. That's a nice blood pressure right there. And then it goes up to 135 over 85. And you can see that the relative risk just skyrockets. Okay? Just increases more and more as your blood pressure goes up. If you've got a blood pressure like this, you have a very high risk of cardiovascular disease. Okay? Because this high blood pressure, this constant pressure on these vessels, is a bad thing. Okay, so we want to control our blood pressure. Um, we've mentioned this before. We've talked about this before, and so I'm gonna just keep it very simple here, as simple as I can. And we have sympathetic and parasympathetic activation. Okay, so when we have sympathetic activation, norepinephrine is released onto blood vessels, binds to alpha receptors. In the heart cell, or in the heart, you have beta receptors. So you have things like beta blockers, which slows heart rate. This is an alpha receptor. And so your sympathetic neuron will release this onto the blood vessel, and it will cause that blood vessel to constrict. Okay? All right. So the constriction, remember, increases resistance, which increases pressure, okay, by 1 over something to the fourth power. It's going to increase the pressure quite a lot. Okay, now, so if we block this, so if we have some kind of an alpha inhibitor, I guess you could have, then it will, or if you're that's even better. If you're sympathetic, your fight or flight response slows down, then the rate of activation is much more slow, and you don't release as much norepinephrine onto the blood vessel. So the blood vessel responds in the absence of norepinephrine. It will actually dilate, and that's going to lower blood pressure. Okay? All right, so that's one way to control it. And we have several ways to control blood pressure. Okay, so so there's that. There's the controlling the diameter of the veins, diameter of the arterioles. Okay, so that's what we just talked about. These two things here. Um, we can also change the heart rate and the stroke volume. And epinephrine can change the heart rate and stroke volume. So epinephrine can be released into the blood, and it will actually bathe the heart muscle cells in epinephrine, which will cause them to beat harder. It'll hit that SA node, which will cause it to depolarize more quickly. And so that's another way that blood pressure is controlled. So when somebody pulls out in front of you and it activates your fight or flight response, you're going to see certain blood vessels constrict, certain blood vessels will dilate as well, but overall the constriction sort of wins when you have your fight or flight response activated, because it hits things like your abdomen, which is a significant part of your blood supply. But really, it increases this heart rate. Increases the heart rate, it increases the stroke volume, how hard the heart is beating, how fast the heart is beating, which really causes your cardiac output, because remember, cardiac output is just heart rate times stroke volume. So it really causes an increase in your cardiac output. Now, the other thing, and this is going to sort of, when we talk about the kidneys, is blood volume. Okay? This is a pretty easy concept to understand. If you have a body of this size, okay, if that's the size of the body, okay, first of all, you're weird looking. Second of all, that's all the fluid, that's all this body's going to be able to hold. So how much fluid is in there? Okay. Now remember, if you eat a salty diet, or if you eat something that makes you very thirsty, or if you don't urinate as much, this fluid will get higher and higher and higher. Remember, it's a closed system. So more fluid means, so fluid means more pressure. Okay, so you can expand a little bit. It looks like you could stand to expand a little bit on this side anyway. So you can expand a little bit, but not really that much. Okay. Okay. So more fluid means that you have higher pressure. So how do we handle that? Well, we get rid of the fluid. Okay. Who does that? The kidneys. Okay. The kidneys say, okay, we're just going to produce more urine. Okay, so you might take something, so a lot of blood pressure drugs are things called diuretics, which tells you, which basically causes you to urinate more, and you get rid of the fluid and your blood pressure drops. However, the quick ones are going to be controlled in this way by the heart and by um, controlling the diameter of your blood vessels. Okay, so blood pressure control includes rapid responses from the cardiovascular system and slower responses by the kidneys. And we're going to talk a lot about that, and that's why this is included in this section, the kidneys are. So we're going to actually come back and talk a lot about that. So, okay.